Thank you, Professor Douglas, for that very big overall review of this fertility issues in 40 plus women with PCOS. Any questions over there? In the absence of, let me check. Okay, I have a question for Professor Lumsden. Now, this issue of heavy menstrual bleeding in women 40 plus with PCOS, what is the kind of estrogen you would recommend? Would you recommend only progesterones as the first step, or estrogens plus progesterone? Because very often the heavy menstrual bleeding does not respond to progesterone only treatment, even though there may be a thick endometrium. So would you recommend using an estrogen with progesterone in these women with heavy menstrual bleeding? And if so, what is the estrogen you would recommend?
Well, I think that's a very complicated question, in fact. We would only recommend estrogen if there is evidence of lack of estrogen. And I think in a lot of PCOS women coming through the 40s, that isn't the case. And as you mentioned yourself, they've got thick endometrium. And so there's no real sign of hypoestrogenism. However, they need some sort of help with their heavy menstrual bleeding. Now, we do use the Mirena intrauterine system, as I mentioned in my talk, a lot, because it works very well and it gives local delivery of the progestogen. So systemic side effects are very rare. And as you begin to get perimenopausal symptoms, you combine with what I would give would be, where possible, the estradiol 17 beta, which is natural to women. But the data to say that it is a lot better than conjugated equine estrogens, I think I would have to be honest and say are not strong. But I quite like giving by the transdermal route in anybody who may have metabolic abnormality. Usually the problem is that I know that the Mirena is not available everywhere. And so people give oral progestogens. If you want them to work, you have to give a lot. And that is associated with side effects. And so it's not straightforward at all, but you need to watch the endometrium, I think, as you mentioned yourself, in fact.
Thank you very much. And
Dr. Mary, I would like to ask one question.
Yes, of course.
We usually give progesterone, as you said, for a heavy menstrual bleeding or AUB, etc. And we have seen that in WHI trial, not only the estrogen, but the progesterone also was blamed for increased incidence in the breast cancer. So in PCOS women who come with AUB or heavy menstrual bleeding, when we are giving them progesterone, like hydroxyprostol acetate, etc., does it lead to more chances of breast cancer? So should we be careful about it?
Yeah, I think the answer is probably no. Okay. In that premenopausal administration of hormones is not really the issue. It's the postmenopausal or the sort of late menopause, etc., the continued use, I would say. And the data on the use of contraceptive progestogens in breast cancer, I think, are, if anything, reassuring in that sense. However, it is always worth pointing out to any of your PCOS patients who are obese that the obesity itself will increase their likelihood of breast cancer and endometrial cancer. It's often people don't realize that. So it's certainly worth a reminder.
I have a question.
I would like to ask Dr. Kathleen that does use progestogens or estrogen lead to anxiety and depression? Yes, it may be PCOS, but we treat also with hormones.
Yeah, so it cut out a little bit, but I thought you asked if there was a contribution of estrogen and progesterone to the development of anxiety and depression.
Yes,
So
yes.
there's not a lot of data on that. I can refer back to the discussion we had with the birth control pills in the younger women, where from both our study in the adolescents and Dr. Dokra's study in reproductive aged women, showed that birth control pills did overall improve the symptoms on the PCOSQ. And there have been some studies indicating that there are no significant increases in depression, anxiety in that. Of course, there are individual responses. I didn't have any data on replacement therapy with that, but when we look at the SWAN study and others, where they have longitudinal data on anxiety and depression, it doesn't seem to correlate with addition of hormone replacement therapy. So I would say at this point, no, there doesn't seem to be a lot of data to suggest that worsens anxiety and depression. There may be individual responses, of course, depending on the type of progestin. And there's some data that pills and PCOS at any rate may improve some of that.
Thank you. Thank you.
I have a question for Professor Doklas. It was curious that the cumulative pregnancy rate alone was higher in the 40 group when compared to the non-PCOS women. How do we explain that? When there is if you take the fresh cycles, the pregnancy rates are the same. But when you go to the cumulative pregnancy rate, then they perform better. How do we explain that?
So that's related to the fact that, you know, the AMH and the AFC is still higher in the early 40s. And so when these women go through ovulation induction, in general, we get more oocytes. And as a result of which we get more embryos that are frozen. So the studies that have looked at the cumulative rates have shown higher numbers of embryos frozen in the PCOS group compared to the control group. So if you have a negative outcome from the fresh cycle, they come back for a subsequent frozen, and then that cumulative rate, which is calculated based on just the one retrieval, gives them that higher success rate.
Thank you. Any further questions?
Yeah, Dr. Anuja, I would like to ask one question. That many times this PCOS young women come to us and they ask us that when they should get married, or how early or how late they can conceive. So would you like to suggest them to go for egg freezing? Suppose she is of 35 years age and she has not found her match. She says, I don't know when I will get married, when I will conceive. So in such a woman, would you like to tell her to go for egg freezing?
Hi, Dr. Ashwini, good to see you.
Yeah, nice to see you.
So again, I think the counseling for egg freezing is not necessarily different in a patient with PCOS or somebody who doesn't have PCOS. I think the principles in terms of egg freezing remain the same, that the younger the oocytes, at least currently what we understand, they will come out of the freeze thaw better. And then the risk of aneuploidy is still the same. So we didn't really talk about the risk of aneuploidy with the aging PCOS or the control population. So just because their AMH is higher or their AFC is higher, I'm not going to suggest that we could freeze their eggs later because the risk of aneuploidy might still remain. So I would take the whole situation into consideration if a patient comes to you at 35 with respect to her long-term goals, understanding that having eggs frozen is not a guarantee, but it's just the backup that's there. And the same sort of guidelines that you would use for somebody who does not have PCOS. I think the good news is when we do freeze eggs in these patients, we do get a much larger number. What we don't know is how many of these are eventually going to be normal, and when we thaw them, what the outcomes are. And being realistic with our patients is important because we don't want to give them a false sense of reassurance that, oh, they have a larger number in the bank. But on the other hand, it is a numbers game, as we all recognize it. And so there appears to be an advantage for the woman who has PCOS, because in terms of a numbers game, she's going to do fine. In terms of the actual outcome is, what we're going to have to wait and see with the egg banking cycles.
There are two more questions from the audience. One is from Dr. Azul. This is for Dr. Dokras. How do we tackle high basal LH in PCOS women undergoing ovarian stimulation? How do we tackle the high basal LH in a PCOS undergoing stimulation?
So, the LH being erratic and elevated is sort of the hallmark of PCOS, and it's part of that pathophysiology of PCOS. We have understood over time that we don't really use those measurements to guide treatment or counseling because they're so variable. And depending on when they're measured, you may get a low or a high because of the pulsatility of LH. So the question is, what does that high LH do? And it drives androgens. And so we really look at the impact of androgens on ovulation induction. And our study, which was called the OWL PCOS, it really was designed to say, if we suppress the androgens for 4 months with a birth control pill, and then we do ovulation induction, can we improve success rates? And the answer was no. The arm that did better was if you lost weight, and that was the weight loss arm, and then did ovulation induction, you did much better. But by just trying to suppress LH or indirectly trying to suppress androgens did not really change the outcome of ovulation induction. So that's what I would use the androgens to make the diagnosis of PCOS, but once your diagnosis is established, then just go ahead and go down the guidelines of ovulation induction, be it letrozole or Clomid, and start treating them. And I wouldn't be tracking these levels at the beginning of every cycle because they really do not prognosticate the outcome.
Thank you, Dr. Dokras. The next question is for all the three speakers. It's from Dr. Azul. Do we prefer highly purified HMG to other gonadotrophins for ovulation induction in PCOS women? So would you use HMG, highly purified HMG, in preference to other gonadotrophins in PCOS women who are undergoing ovulation induction? To all the three speakers. May I ask Professor Lumsden to give her view?
I think probably I'm not the best person to answer, in that the fertility issues in our patients' assisted conception is dealt with by one of my colleagues. But I think I'm right in saying, yes, he does. But I am not able to discuss rationally the reasons, and I would defer to my colleagues on the panel who will know more about it than me.
Professor Heger, I hope I'm saying the right way. Hoger?
Yeah, Hoger is fine. So yeah, there are several conflicting studies in general about the use of recombinant versus the highly purified FSH. And I can only tell you in our own experience and in most of the clinical trials in the US, there is some evidence that using combination of therapy produces a better response. We do see lower progesterone elevations if we use a purified HMG versus recombinant alone. I'm curious as to what Dr. Dokras does.
No, I agree. It's sort of been out there that maybe using the purified HMG might have some beneficial effect in this particular population, but I don't think the studies are that convincing. And so again, in our practice, we really don't tailor it specifically or use a different protocol. The difference in the protocol would be more to be able to use an agonist as a trigger to prevent OHSS, and that's our bigger focus, rather than changing the combination of the gonadotropins. Yeah.
So thank you very much. And since there are no more questions down there, thank you, Professor Dokras, Professor Hoger, and Professor Lumsden for your contribution to this conference. And thank you very much for your presence.